Hello, everyone. We're going to get started with our next session. If I can have everyone take their seats. Wow, that's working. Very good. I'm going to do this quickly. I'm Cheryl Pigas. I'm the director of the Division of General Internal Medicine and Clinical Innovation here at NYU. And it's my pleasure to introduce our third plenary session, Making the Research Case for Integrating Oral Health with Overall Health, Compelling Data. And so I have to say a couple of things from this today. This has been a really, really great day about education. We actually heard someone say, what about getting it into practice? And so I like to remind people that we do the things we measure. But the things we do and we measure and do research on are the things that actually get paid. And the things that we really have to talk about is how do we take our research and turn that into payment. The only other comment I would make that has not been said, we talk about the patient as the one we're all trying to get to, but we keep asking them to come to us. And I think the innovation of how we go to patients with utilizing mobile technology, online technology, and even our partners in retail health, where everyone enters, are really some opportunities for us in healthcare. Not just in dental, there's a lot of work to be done in internal medicine and in my area, cardiology. With that, I'd like to introduce you to your moderator today, someone who I've known for quite some time, Dr. Elsbeth Kalenderian. I've known Elsbeth since actually the times that she worked at the American Heart Association working on quality. She, from there, went on to Harvard as the Assistant Dean for Clinical Affairs in the Harvard School of Dental Health, then their interim chair for Oral Health Policy and Epidemiology, then the chair. And recently, actually in July, she became the chair of the Department of Preventive and Restorative Dental Services and a professor at the School of Dentistry at UCSF. She's also, talking about data and EMRs, the PI in research focused on dental diagnostic terminology. With that, I give you your moderator, Elsbeth Kalenderian.
Thank you, Cheryl, for that very nice introduction. I have indeed worked with Cheryl for a long time, and indeed, I didn't know that, but there is life after leaving the AHA. It's amazing. Okay. So how does it go? Like this? Yeah, okay. There we go. So I just love this slide from the WHO. I'm just putting it in here for 1 second to remind all of us that interprofessional education, drives collaborative practice. What is so interesting for our dental students is that they really provide care, where the medical students don't. The residents do, but the medical students really observe. So for us in the dental school, it's really important to think about IPE and IPC, and therefore also about the practice. And sometimes, when you talk about in these IPE conferences, we forget about that. And we are, in the dental schools, we're a little bit different. And certainly if you have dental schools that are different than medical schools where, as in Harvard, where we are the only entity that sees patients because the medical school is somewhat separate from the hospitals, it gets a little bit forgotten. So it's important, but in this panel we're talking about research, and so the research on how well are we doing with IPE, how well are we doing with the collaborative practice. And I want to take you back a little bit and step back a little bit. And why is this important? That's a really important question for me, because it is about being integrated. Primary care, dentistry, and all other professions, health professions, need to be integrated and need to be important partners. If you think of and this comes from Bell and Health, and I love this pyramid. On the bottom, it's all about self-care. Self-care needs to include oral health, from how your patient accesses the portal, are the right questions in there, to fitness, nutrition, wellness, is your patient, is the client flossing, to retail clinics. Not only are we giving flu shots, but can we maybe do some fluoride in the retail clinics? okay, the CVS's or the Walgreens or whatever is in your state. And then obviously primary care physicians and integrated dental service, how they are coming together before we go up to quaternary care. Okay, so this is the new version. All right, Rachel did it also. So Rachel Maroney does all these wonderful slides for us. This is the triple aim on steroids. And so what is really important for when I look at the triple aim, besides that, obviously, what the reason is for the triple aim, and we talked a little bit about this in this last panel, is interoperability between EHRs really helps drive the triple aim. And what helps drive interoperability is that we speak the same language. And if you're like me, I do a lot of secondary data analysis and research. You need to have diagnostic terminologies between medicine, dentistry, nursing, any of the health professions that are integrated. And they weren't. If you think about ICD, had only 350 dental terms. ICD-10 doesn't even have recurrent caries in it. All right? Little hard if you want to do any kind of secondary data analysis and how well your patients are doing. But the good thing is that has changed. For those of you who are familiar with meaningful use, you know that in your electronic health record, there are now SNOMED terms. If you're not familiar with that, then you're familiar with ICD. SNOMED is essentially ICD on steroids. Has about 1 million terms in there. ICD, few less. But SNOMED too had no dental terms in there. SNODENT is the oral health version of SNOMED, had been in development for a very long time by the American Dental Association. And when Cheryl talked about that I've had or have grants around dental diagnostic terminologies, that's the piece that I've been working on. And we've been finally able to work with the ADA, get all the terms into SNODENT, integrate them and harmonize them with SNOMED, but then also those smaller circles are actually making smaller, what we call RefSet, that are actually practical for the dentist chair side. And they're now an NC standard, which is just like your grams and your ounces are an NC standard, so that now the ADA is endorsing it, which makes it easier for the electronic health record vendors to actually use them. And so indeed, Epic now is very open to use SNODENT and the smaller RefSet into their wisdom, and that is moving Health Partners and Kaiser much faster forward. And why is that important? Because they have not yet adopted it, but also payers have not really required coded dental diagnosis because they want to be comfortable with the ADA, and now they are. And on the health profession side, it helps align incentives, and it helps also think what is important also for interoperability, that more of us are thinking about quality dashboards. And for me, the easiest quality dashboard to think about is meaningful use. Although another part of me says we should be done with meaningful use, and certainly John Halemka thinks so. But if we think about interoperability, it's a good way to start. And why do I think that? Because we need to think about formal relationships between primary care physicians and other health professions. We talked about the classifications. And when we adopt it across the health professions, we can start thinking about quality improvement. And we talked a little bit about reimbursement. Let me talk about meaningful use. This is about 50% of physicians. This is about 14% of dentists. Okay? The dentists are not yet thinking about quality improvement and measuring quality improvement. And like Cheryl says, if you're not measuring it, we are doing the research on it, I'm doing the research on it, but if we're not measuring the outcomes, you won't get that payment. Okay? And we know on the medical side, the meaningful use payment is coming. And knowing at these numbers, those dollars, I know that it's not just year one, but it's also year two. Those quality incentive payments, the quality components are being paid for. So we're doing well on the medical side. We need to do better on the dental side. This is the problem. 632 IT vendors. This is where the interoperability piece is an issue. Okay? Lots of work to be done. So we know from the research that early introduction is important. It really helps with patient satisfaction, health outcomes. There's little information about how does that works with the other students. What we also know from the research is, we use different synonyms, we use different definitions. So we need to work on that when we write about IPE. We have lots of good questions. So what we're going to answer in this panel today is these 5 questions by these 5 panelists. Okay? A little bit about perio and chronic disease, care management and data analysis, a very interesting piece about behavioral interventions and how can we improve oral health care in patients with dementia, a piece about tobacco use treatment, and we haven't seen a lot about that today, and then predicting and managing dental caries in the primary healthcare settings. So with that, I would like to introduce our first panelist, Dr. James Bramson. Is the Chief Dental Officer from United Concordia, and he will speak about protecting more than just your smile, oral wellness.
Thank you. First off, it's great to see some old friends again here. It's been a little while, so I like that. Secondly, I've decided I'm going to live to 97, so that's 1 more year longer than Hal. And we used to refer to that narrower set as Snowdent Light because it had just enough codes in it that you could actually use it. So anyway, we're going to talk a little bit about some of the research that we did at United Concordia and what we've done with some of that. This is what Mike referred to as the Jeffcoat study. So we'll talk a little bit about the use of dental claims. Somebody asked me once, well, why did you just use dental claims? And my answer was, I didn't have anything else. It's a dental insurance company. That's the data that we have. The beauty from our standpoint is we're partnered with a medical carrier where we could then make sure we looked at those medical claims that connected with it. So we've said this before today, the mouth is the missing piece of total oral health. And you all probably know this. I think when I first saw this data from CDC and it was put up by AAP, it's just really 38.5% potentially of these folks over age 30 have severe to moderate to advanced periodontitis. I mean, that's 1/3 of the people over the age of 30 that have a fairly substantial level of periodontal disease that we should be concerned about. So there's a lot of folks out there, and a lot of people have chronic diseases as well. This is probably even small based upon if you looked at people that were pre-diabetic and things like that. So there's plenty of place for us to take a look at where we can have an effect through the integration of medicine and dentistry from a cost standpoint, because there's a lot of chronic disease out there. Diabetes being the biggest one of them, I think that's the one that we talk about the most because there's more of those folks. It's a lot more prevalent, and the data is out there about the kind of expenses that diabetics cost employers, the kind of health effects that they have, and even the fact that it's the 7th leading cause of death in the United States. So here's a little bit about our study. First of all, let me just mention to you how we're aligned with Highmark, which is where we got our medical claims from. Highmark is a Blue Cross Blue Shield licensee that has a footprint in Pennsylvania, West Virginia, Delaware, and all over in Pennsylvania, short of the eastern side of the state where Independence Blue Cross is at. They own United Concordia. So we're joined at the hip with a medical provider who's been in the business of delivering Blue Cross Blue Shield health insurance for a long time. Highmark, however, owns 7 hospitals and affiliates with about 800 physicians who are affiliated with those hospitals. So it's very much an integrated delivery and financing system in the western part of Pennsylvania. In addition to owning a dental company, they own a vision company, VisionWorks. So they have vision insurance, as well as a company that makes glasses frames, as well as a company that makes the lenses, as well as a company that actually has 800 retail outlets to sell glasses. So they very much have this vertical structure, and they also own a captive risk insurance company that can do stop loss. So when you look at the opportunities to potentially put together a medical dental delivery system, Highmark seemed to be one of the nicer platforms around. So what we did is we got access to their data, looking from the years 2005 through 2009 to try and ask the question of, if you had medical insurance through Highmark, and you had dental insurance through United Concordia, you had to have it for all of those years consistently across that company, so you couldn't come in or out. That way we knew that the folks got their medical care solely through their Highmark insurance, and they got their dental care solely through us. So we didn't try to mix anybody that got their care someplace else or left our plan or their plan fell out of our study. We did that by then looking at how many of those folks consistently were covered by both of those two plans for those years 5 through 9. There were 91,000 of those who were diabetics that had periodontal disease. Now, this is the first place where some people sort of say, well, you didn't have diagnostic codes, so how did you know that they had periodontal disease? I admit to you, we did not have diagnostic codes. What we did is we went in and we took a look at all of those people who were diabetics and asked the question, did they get a dental treatment for an inflammatory periodontal condition? So it wasn't all the periodontal codes, it was simply those ones that would be connected with an inflammatory condition. Making the assumption, yes, it is an assumption, no one goes in and gets periodontal treatments for an inflammatory condition if they don't have periodontal disease. Okay? I mean, I haven't seen anybody walking in yet that says, today is my day to give me some perio surgery, please. I don't know what it is, I don't know why I need it, but I think I want it today. No, okay? So that's how we found out. We looked at people then who were diabetics who had perio disease, and we defined that perio disease as they got their initial inflammatory condition treatment done in the first year of the study, and then we followed them for maintenance thereafter for the remainder of the study. So you ended up with two cohorts, people who had diabetes, who had perio disease, who had it treatment, and who maintained it in one group, and those who were diabetics, who had perio disease, had it treatment, but did not maintain it. Those were our two cohorts, so that we could go back and look and sort of say we tried to adjust for the fact that we needed to know that you had perio disease, we needed to know that you had a treatment, and what we were trying to determine is, did you take care of it thereafter, and what could we see in the effects thereafter. Then we went back to the medical claims from Highmark and looked at their medical costs. That would be all the costs associated with the visits to their physicians in their offices, and the cost associated with their hospital admissions. That was the first part of it. We eventually went back for diabetics and looked at their pharmacy costs. I'll talk about that in a second. So what you had is those two groups of people, okay? So we put that together, and as mentioned, Dr. Jeffcoat was working in collaboration with us. She presented 2 papers with this data at AADR, one in 12 and one in 14, and then we published our article in the American Journal of Preventive Medicine in 2014. So just as an example of one of the data plots here, for any of those diseases, those chronic diseases that we found any significance to, the data plots look pretty much like this. I just put the diabetes one in here. But so you take a look at the ones in black there are the people that got treatment and then were untreated thereafter, and the ones that go in the red were the ones that got treatment and stayed and maintained that. And you can see the difference there. So sometimes people say to us, we adjusted this for age and gender and all the things that we could, okay? But some people say to us, well, maybe these people were just inherently different in 2005. Maybe they took better care of themselves regularly, maybe they were runners, maybe they joined a gym, maybe their company had a wellness program. I mean, 101 things that could have gone on to sort of say these people were inherently different from the beginning of the study. Our answer to that is if they were inherently healthier at the onset, those two data points would probably not overlap at the beginning of the study. They probably would have had some differential to the start and then would have diverged from there. So we think that's our best explanation for that part of it here. We also took a look at women who were pregnant in this. It wasn't part of our initial design. We were just going to look at chronic disease folks, but there were a number of pregnancies in there, and by first here it means in the years of the study, this was the first child of that woman. It's not necessarily their first child ever. It was the first child in that study, and second means it was their second child in the period of that study. And the reason that the second is non-significant is because there were very few of those, as you can imagine, 2 babies in that period of time. And there's a substantial difference in the cost there of those pregnant women who were treated versus those who were untreated. This is the data that's in our paper that shows the significance and the values there. The first paper we did that we presented to AADR, we actually found some significance for rheumatoid arthritis, but we had done analysis of variance in that first study, and in the second one we did a covariance and adjusted for type 2 diabetes. And so we think the diabetes component, because there was so many of the people with RA that had diabetes, that was probably masking that, which is why in the second study we did not find a significance for the RA folks. And a pretty big difference there for those folks who were had their pregnancy, as well as the inpatient hospital admission. So the difference here, if you add that up for all kinds of things, for those that had a stroke, it was about $5,681 per year less medical expenses than those people who were treated and did not, or that took care of that. The pharmacy expense, when we went back to it, was about $1,500, as you can see there. So for a diabetic, it was about $4,200 a year annually and a lower medical spend. So that's a lot on an annual basis. That can pay for a lot of dentistry, frankly. So what that means to us is that this is a pretty significant reduction. And as you saw by that data plot, we were still seeing that 5 years after that initial treatment there, as long as they were maintained. As Bruce said, this has led to a symposium, a paper and a symposium at Harvard, and I appreciate the opportunity to work with Harvard on that. The idea there is, the title of that particular symposium was "Put Your Money Where Your Mouth Is," which we were trying to highlight that here's an economic way of looking at this problem. Everybody else can look at it either systemically or medically or from an outreach standpoint, but who's looking at, the sort of economic value proposition here, which is really the basis of the Harvard initiative that's been put together. We've got a number of things that are going on there. Our next forum is October 31, November 1st. Jane here is our executive director of that, Jane Barrow. So here's some other things we did with it at our company. We integrated this into our outreach programs. There's a lot of things that companies do. They do newsletters, they do podcasts, they do things. So we help them with that. We help them with lunch and learns. We give them information. We write stories for them. We have client coordinators that can go out and help our clients. We changed here's a medical term, we rejiggered our benefit. And by that I mean we improved the periodontal benefit for people with chronic disease. They get more perio, more frequent perio, higher paid perio, those kinds of things. Surgical perio is 100% covered for those folks. So what we were trying to do is change the benefit to say, I don't want your dental benefit to be the financial reason why you don't go get your care done. And then we have that available to clients out there. It's called Smile for Health Wellness. We think that that's another way of getting to the triple aim. We have about 3.5 million people on a benefit program. We have about 10 million insured overall at our company. We have about 3.5 million of them that have this expanded wellness benefit. So it's been very well received. And I think that's my story. I'm going to stick to it. Mary Lee will tell a similar story. They did research. Everybody did their research a little bit differently. And I think the beauty of the fact that we did ours one way, they've done theirs a different way. We're all seeing that there's an effect here. Okay, so you can criticize that it's claims data or perhaps this was out, but the data is across a lot of different points, a lot of different companies, and a lot of different people who are looking at claims data is all showing the same thing. That might not be the exact same value, but we're all showing the same thing. Pretty good sized cost savings that's there if you treat people with chronic disease for their perio, and you can save some money on the medical side to do it. Thank you.
Thank you, James. Okay, so next up is Mary Lee Conicello. She's the Chief Dental Officer at Aetna, and she will talk about making the research case for integrating oral health with overall health using Aetna's data.
I want to thank Judy so much for inviting me to come to this. So far, it's been just a phenomenal conference, and I think we'll be able to accomplish some things after tomorrow. Everybody wants data to explain everything. And what's so ironic to me is that it was a huge news story a few weeks ago that there was no data around the effectiveness of flossing So now everybody's talking about it, and it got so much press, and oh my gosh, there's no data, so we shouldn't floss anymore. How did that make the news when we've had all of this data? Jim and I have presented this at a lot of conferences. It never makes the news. So it is kind of ironic what people latch on to. But so my presentation is about making the research case for integrating oral health with overall health. But I also think there's value in how interprofessional collaboration can improve data analysis. So it kind of works both ways. And so let's look at what are some cool things that can happen when you manage care and you can do data analysis based on that care coordination. So the first thing is that it allows for cross referrals. It's very easy to get providers to refer to one another. And then when they're doing that, good data analysis can lead to better communication between those referring providers. Everybody's talked about it, especially on the previous panel. You can share patient health and treatment records. And then it can expand evidence-based care. So the more data you have, the more evidence there is, and it helps with clinical decision support systems. Based on data and evidence, then you can recommend certain treatments. And what I really find fascinating is that when you can get good data analytics, you can make decisions, be predictive. That's what happens with a lot of data, and a lot of health insurers like Aetna use software programs that make predictions based on the data that they have. And you can really get patients engaged. What I will say about the data analytics, and it came up earlier about pharmacy. Why aren't we talking so much about pharmacy? All of our data at Aetna is on the same platform. So like while in Jim's study, they were able to use Highmark's data and then combine the two, all of our data is always on the same platform, so it's pretty easy for us to integrate. And what we've done recently with pharmacy is with this huge opioid epidemic in the country, we've done some recent analysis where we can look at dental claims and then pharmacy prescriptions that were filled related to those dental procedures, and it will allow us to look at certain dental providers and see what they're prescribing for procedures that might not really need a narcotic prescription. So you can do so much with data. So the flossing thing was in the news and got so much press, but there's no lack of studies about connections between oral health and overall health. So studies about stroke risk and kidney disease and respiratory disease and heart attacks, all related to oral health. So we know that there's lots of data out there. Aetna's first study with Columbia, a little school north of here, was published in 2006, and this was our study where we looked at periodontal treatment and really all dental treatment and chronic conditions. It was published in 2006 in Biomed Central, and this is one of the results of that study. We looked at diabetes, coronary artery disease, and cerebrovascular disease, and we looked at risk scores. So I mentioned that there's software that you can do predictions. So if you have a high risk score in these conditions, it means you have more risk of having complications. And what we found was that for members who had dental care and most specifically periodontal services, and I have that highlighted in yellow because to Jim's point, you'll notice that we had to use the fact that they had periodontal services as opposed to having a diagnosis of periodontal disease because dentists aren't using diagnostic terminology, but people who had periodontal services had lower risk scores, over 20% lower risk scores for each of those conditions, which is pretty significant. And then we published another study in 2011 in the American Journal of Public Health, again with Columbia, where we looked at pregnancy. So again, in yellow, we looked at women who received periodontal treatment, assuming that that meant they had periodontal disease. We also looked at women who had any dental treatment, and then at the bottom, you see the results for women who had no dental treatment of any kind. And so based on the science emerging around oral health and pregnancy, and that periodontal disease predisposes to preterm birth or low birth weight, we found that in our study, looking at over 30,000 women, and by the way, in the previous study for the chronic conditions, that was over 700,000 members. So this was 30,000 pregnant members. We found that the women having no dental care of any kind, either right before or during or just after their pregnancy, had the worst birth outcomes, the highest percentages of low birth weight and preterm delivery. So that led us to creating a formal program in 2007, and it's still in place today, where we use all the data on that platform that we have, and we identify members from their medical data as having diabetes or heart disease, or members who are pregnant, and then sort of a vast list of conditions related to those three main categories. And if they haven't been going to the dentist, we do outreach and we give them education, and we're very successful in getting those people to go. And we continue to do internal data analysis on the members in that program, and we find that the members in that program who are getting dental services have, just on the dental side, more preventive dental care and need fewer basic and major services. So that's a great result just on the dental front. But we also find that they have lower medical claims costs, and they require fewer hospital inpatient admissions, which is really the most expensive medical event you can have, is being admitted to the hospital. And we find that they have 45% better control of diabetes, because we also have in our data their hemoglobin A1C results. So we're seeing great results in our membership following them once they're in this program, and they're being identified, targeted if they're not going to the dentist, encouraged to go, and then they get dental care. We are still doing studies with Columbia. In fact, one is in the process of being submitted to a journal as we speak. It's a follow-up to our pregnancy study, where we're looking specifically at intrauterine growth restriction as the reason that women are having birth problems. And then we're also, Columbia is working with us on a bigger study from the members in our formal dental medical integration program. So those results will be coming soon. So what's the future state? Well, this is not news to anybody. We know that Americans are getting older and sicker. So by 2023, there's projections for how many millions of people will have chronic conditions, and these are the chronic conditions that we know have a connection with oral health. And we also know that the U.S. population is aging, so again, more people will have these chronic conditions, so it's more important than ever that we are working interprofessionally and coordinating care and making sure people have good overall health, and because they will need to have good oral health to make that happen. So consumers are driving new care models, and this is really big for us at Aetna. This is a way that we feel that we're transforming healthcare. We're really focusing on the consumer, on our member, and making things convenient for them. So we're looking at on-demand care. So how everybody has a minute clinic or an urgent care center close to them, and it's making it easy to get health care quickly and on demand. Concierge medicine. So at Aetna, if for any member that has multiple products with us, so at least 2 products, medical and dental, or medical and behavioral health, or any combination, then you have a health concierge from Aetna who helps you coordinate your benefits and your care. We've all heard about telemedicine, that it's up and coming, and even dentistry is getting involved in telemedicine. So that's something that's the wave of the future. And then digital health, care, looking at things on your phone, on your cell phone, mobile apps and Fitbits. Certainly, consumers are really adapting to that whole digital health model. And this slide looks like a lot like Ken's slide from Kaiser, where the member is in the middle and all these strategic partners are around the circle focusing on the member. And at Aetna, it's no different. Our goal is to coordinate all of these services, and you'll notice clinicians are in there, meaning dentists, physicians, nurses, and pharmacists are in there, and behavioral health is in there. And the whole concept is to make those things easier for the member, coordinate those as best we can so that it's a seamless process for the member to be as healthy as they can. And that's another of our goals at Aetna, is to not just be concerned with members who are sick and covering procedures for them when they are sick, but making members as healthy as they can be every day and not waiting for an incident or an episode where they need care, and making that convenient. So this is some Aetna data, not dental related, but overall Aetna data on some great outcomes when care is coordinated. So I mentioned we have that health concierge, and if you have multiple products with us and they're coordinated, there are great outcomes from that. So we've seen improvements in cancer screening rates. We've seen fewer diabetic members that are poorly controlled. We've seen reductions in radiology services, increases in generic prescribing rates as opposed to brand prescribing, reductions in avoidable surgical admissions, as again, another very expensive part of healthcare, reduced risk for hospital readmission, and fewer visits to the emergency department, all because care was coordinated. And I will just put in my plug, I'll wrap it up. But going back to what Elsbeth said, use of diagnostic terminology is really important. It would be great if we could get dentistry on board with using diagnostic terminology, and these are all the advantages to that. So thank you.
Thank you, Marilee. The diagnostic piece should be easier now. Putting in my plug. Okay, so next up is Dr. Vida Jablonski. She is Associate Professor at University of Alabama at Birmingham School of Nursing, and she will talk about soaring over the hurdle of care-resistant behavior and providing evidence-based mouth care to persons with dementia.
Thank you. I think my title is longer than the actual slideshow, so sorry about that. I am a nurse practitioner, and I spend a lot of time in nursing homes, and I'm going to walk around here because I'll fall off the stage. Be entertaining. Anyway, my contribution to this panel is talking about taking research findings that usually wind up in peer-reviewed journals that nobody reads and translating them into practice. So they're coming up, the slides? Or was I supposed to do something? Oh, okay. Whoops. Thank you for your tax dollars. The National Institute of Nursing Research funded this study, and without your contributions, it wouldn't have happened. So thank you. That's the commercial. We all know, based on what Dr. C has just talked about, that mouth care is basically oral infection control. In nursing homes, however, mouth care is considered nothing more than grooming. I brush your hair, I brush your teeth. Therefore, it's frequently overlooked. And we talked about autoimmune diseases earlier this morning. The literature is showing some thoughts that perhaps rheumatoid arthritis may be linked with poor oral health. So that is emerging. So nursing home residents predominantly have cognitive impairment. 63% of people in long-term care have some type of behavior that's considered a behavioral or psychological symptom of dementia. The main one is refusal and care resistance. The minimum data set also calls it care rejection. And the thing is, mouth care triggers care-resistant behavior in 98% of the times. And when nurses are asked, when someone fights during mouth care, what do? 95% say, I walk away. So people in nursing homes, especially those with dementia, have extreme oral health care disparities. Now, the term dementia, it's an umbrella term meaning forgetful. There are many types of dementia, like Alzheimer's, Lewy body, Parkinson's disease, frontotemporal syndrome. I'm just going to use the term dementia. Otherwise, I'll put you to sleep. Okay, the question we brought to the study was, how can we use behavioral interventions to provide evidence-based care to people with dementia who often resist care? And we came up with the mouth. You come up with the acronym first, and then you mush everything. But it was managing oral hygiene using threat reduction strategies. We took best mouth care practices that we culled from the dental literature and the nursing literature, and then I combined it with my understanding of neurology, and I'm going to talk about the rationale for the intervention. Mouth care is literally a double invasion. I'm getting in your face. And people with dementia do not process threat the same way all of us do. Rah! Okay, I just activated. I do that with undergrads. Anybody have chest pain? I feel really bad. I do know CPR, and you're all awake. But what I just did is I triggered your autonomic. Yeah. Okay, now I'm going to use you as a patient. Sorry. I triggered your amygdala, which is hardwired into your autonomic nervous system. So I was an immediate threat. You did not have to think. You reacted. If you now that I've done it, if I were to go do rah again, you wouldn't react because your hippocampi provided context. And your hippocampi is telling your amygdala, chill out. She's just some crazy broad up there doing weird stuff. And your cerebral cortex would also rein in the amygdala. So for those of us who do not have neurodegeneration, different parts of our brain take the little amygdala and say, stop it. So if I were to see a snake or a spider, I could talk myself out of the fear. With dementia, those abilities decrease. The more neurodegeneration, the less you are able to rein in that pesky amygdala. Therefore, one of the things I see all the time in long-term care, and also in my practice, I practice in memory disorders clinic every Thursday. Thank God. I love to practice. But I see caregivers who try to approach people with dementia with logic and arguments and all sorts of ways and trigger the behavior. And then I have nursing assistants who say things like, okay, come on, we're going to go brush your teeth, let's go, and then start dragging the person down the hall. And if you aren't understanding all of this, if you can't keep up, what are you going to do? Resist. Who's this person dragging me down the hall? I want to go home. So we took all of these strategies and we first started with preemptive strategies. So what I did is I hired nursing students, dental students, anybody who basically answered the ad, and we interviewed them, so we did do some, quality control there. That sounded just terrible. But I trained the experimental mouth care providers to go into the nursing home twice a day for 3 weeks and provide mouth care to the people enrolled in our study. What inclusion criteria did we have? You must have dementia, you must be 55 or older, you must have at least 2 adjacent teeth so we could floss, or have at least 1 denture plate that you used on a regular basis, or a combo, and you had to resist care. So basically, we targeted a population that had been systematically excluded in 30 years of research. And the nursing home thought I was crazy. And the best part is, they loved us coming in because we walked in and performed the mouth care. I did not rely on staff for a variety of reasons. I also had my control mouth care providers, and we trained them to simply provide mouth care. And principal investigator should not stand for practically invisible. I was there a lot, and so was my program manager, because we had to do treatment fidelity, cross-contamination. I had a member of the experimental team dating a member of the control team. That was awkward. So they both wound up on the experimental team at some point because God knows what they were talking about. Anyway, so the preemptive strategies were first, the experimental mouth care providers were trained to assess the person as they approached, figure out what mood they were in, and their approach at or below eye level. Don't come and tower over the person. Smile. Okay, because when you smile, you're not seen as threatening. Gestures and pantomime. Sometimes we talk too much with people with dementia and all they hear is blah, 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 blah. That also works with teenagers, by the way. You gesture and pantomime at them. Short, simple requests. Sometimes we say too much. Please come here. Here's your toothbrush. And then gesture and pantomime as you're doing it. Avoid elder speak, which is that high-pitched baby talk. And as I age, I notice more people in the retail industry do it to me. And I know I want to rip off their throat, and so if I had dementia, no wonder I would be upset. Kristen Williams has done some amazing research where she has shown that one of the key precipitants to a violent behavior is a nursing assistant engaging in elder speak and the person with dementia smacking the nursing assistant. Chaining is when I start the toothbrushing and let them take over. Encouraging self-care. As neurodegeneration increases and acetylcholine levels go down, people move backwards in time. And if I brush your teeth, you may lose the memory of how to brush your teeth, and therefore you don't have enough acetylcholine or neuronal growth to learn how to do it again. Once the care-resistant behavior occurred, we would engage in distraction. Singing was the most common. I had one lady who would only brush her teeth when I sang or the mouth care provider sang, "I've been working on the railroad." And one day I was working with the team, and she was singing while she was brushing her teeth, and I was afraid she was going to choke, so I stopped singing. And she took that toothbrush and she popped me on the head one, and I started singing again. And she started brushing her teeth, and the nursing students thought that was the height of hilarity. I think there were some tweets about that. Bridging is when I have someone hold the object related to mouth care to help kind of grab procedural memories so that they'll cooperate. Hand over hand, I put their hand on mine. That works really good with getting dentures out of the mouth. Because if I just go stick my hand in your mouth, you're not going to like it. But if your hand's on top of my hand, you'll probably think that is your hand, and it works really well with getting dentures out. Mirror, mirror, we put the person in front of a mirror, and I get out of their way, and I do mouth care from behind. As the person's looking at themselves in the mirror, it's triggering procedural memories. Also, it kind of helps if you do mouth care in the bathroom standing in front of the sink. I was a nursing assistant 35 years ago, and I used to put people on the toilet and have them pee and poop while I brushed their teeth to save time. Well, I don't know about you, but I don't sit on the commode and brush my teeth. So I was creating care-resistant behavior without a clue. Using a toothbrush as a bite block, when they clamp, I use the toothbrush as a fulcrum, get another toothbrush, and off we go. Requesting help from the older adult. People still want to have a job, they want to feel important, and with dementia, the outlets greatly diminish. So when I say to someone, "Can you help me? Could you help me, please?" They go, "Sure," and I walk them into the bathroom, and they help me by brushing their teeth. Entering his or her reality. "Okay, ma'am, we're going to brush your teeth." And the person looks at me and says, "I just did it." And then I stand there and argue, No. "Oh, okay, you did just brush your teeth, but you just had breakfast, so let's go brush them again." And they go, "Okay," and they go in. Rescue. If I am like going down in flames, maybe it's because of my red hair, maybe I look like a sister-in-law, maybe I don't know, maybe it's just me. We get another provider to come in and rescue the person, and usually that worked a lot of times with different genders. Like if I had a female mouth care provider who was going down in flames, the young man would walk in, and the female resident was very happy to go with him. And I had some male residents who didn't like the male mouth care provider, but they were happy as a clam to go with the female mouth care provider. So, okay, like a typical academic, 10 pounds of slides and a 5-pound talk. So I talked about the study. The big thing was the findings. We found improvement, but we didn't find it statistically significant. And part of it was the confounder. I had an active control. And my control group tended to receive mouth care from a smaller pool of mouth care providers. So I accidentally stumbled on support for consistent staffing. Who'd have thunk, right? And we also had improvement in oral health. The lower the number, the healthier the mouths. Again, not statistically significant, but I was using a clinical tool. For my next study, we're going to be using an intraoral camera, and that's going to be really cool. The big take-home message is people receiving experimental mouth care were twice as likely to agree to mouth care and to accept the mouth care and to complete the mouth care, which included flossing. So what is the impact? We have some really cool cue cards here that the Washington Dental Foundation has taken all of the interventions and they put them in these handy-dandy books here, and I have about 4 left. So Judy's going to, I don't know, silent auction, do something, raise money. You have to buy us a drink and get one. But these are available free from the Washington Dental Service Foundation, who have partnered with various Alzheimer's Association groups. We've distributed 6,000 of them, plus about 2,000 or 3,000 in Spanish. And I also have a video on how to provide mouth care on YouTube. I had the video as part of the research study, and we have it on YouTube now, so anybody can get their hands on it. And we're looking at a civil penalty money grant that we're working on right now to submit. Because ultimately, can we use mouth care to prevent pneumonia and upper respiratory infections, and thus prevent rehospitalizations? Thank you for your kind attention.
Thank you. Our next speaker is Dr. Donna Shelley. She's Associate Professor and Vice Chair for Research, Department of Population Health, and Co-Director at the Section on Tobacco, Alcohol, and Drug Use here at NYU School of Medicine. And she will talk about tobacco use, treatment, a case study in linking oral and systemic health in dental and primary care settings.
Thank you. Let me get around this way. So I, too, want to start by thanking Judy and Dan for inviting me. It's really a pleasure, and it's so much fun to see all my old friends from the College of Nursing and Dentistry here. So I was really actually inspired by the last panel because I'm going to talk about all the problems we're still having in New York City. We haven't quite figured it out the way that KP has and Health Partners and others out of the West Coast and in Minnesota. But it's nice to see a way forward. We in New York City are really struggling with a lack of integrated health systems here. I sort of didn't follow the rules exactly. I'm not going to be showing you data specifically from my studies. I thought it actually gave me a chance to reflect actually on the work that I've been doing over the last 15 years in tobacco use treatment and trying to implement tobacco use treatment guidelines in both primary care settings and dental settings. And honestly, it's a little disorienting at times. The systems are so organized so differently. And it's been challenging to try and create some synergy and some similar systems in both and seeing what the challenges are. So hopefully that will be satisfying to folks here. Just to know where this work comes from, and for the past 12 years, I've had funding from the State Health Department Tobacco Control Program, which is, I think, the only tobacco control program in the country that funds the implementation of tobacco use treatment guidelines in primary care settings. And also just to acknowledge that AHRQ funding and some of the current NCI funding that I have to work specifically in dental settings, and I'll tell you a little bit about that study. So tobacco use treatment should be a layup. This is actually the most cost-effective, most highly evidence-based preventive intervention we have in healthcare. And it's actually really easy to put to an algorithm. It's just not complicated. This isn't diabetes care. This isn't hypertension care. It's actually very straightforward. Do you smoke? Are you interested in quitting? How many cigarettes do you smoke a day? That drives the NRT prescription. And if you don't want to use NRT, I'll give you some Chantix or Zyban. In fact, if you look at the evidence, there are really only 3 options. There's Chantix alone, there's combining long-acting and short-acting nicotine replacement therapy, or there's combining Zyban, which is Wellbutrin, and nicotine replacement therapy, based on multiple meta-analyses and the most recent EAGLES trial. Those are your three choices. So again, it's really pretty straightforward, and we successfully kind of created that very, very simple algorithm in the School of Dentistry with Mark, unfortunately, isn't here still, Mark Wolf, who's been an important mentor for me and colleague and real visionary in trying to really get tobacco use treatment integrated in the College of Dentistry's clinics, and has been very successful in doing that. We had some funding from AHRQ to create a very simple algorithm that did just that, where some people might criticize it because literally the students don't have to think. They just click through and it will tell them what to do. But in fact, you might say that with smoking rates going down so much in New York City, you don't see smokers as often. And frankly, the students were telling me, Donna, I don't remember what you told me to do. Like, which drug was it and what's the dose? So we made it really simple for them. I'm going to show you what it looks like. So the issue with this, too, is why this is so simple that it should look the same in a medical practice as it does in a dental practice. There's no reason why there should be any difference in the way these two settings manage this issue. And so it's been my life's work to make that a reality. At the end, though, I will tell you that I'm giving up, I think, on frontline providers altogether, and decided that behavioral health will never be adopted completely in those settings, and we should go direct to consumers. And I'll just end, actually, with an example of something we're doing now, which I think would apply to dental settings as well. So obviously this slide isn't necessary here, but the reason why I put it up was to remind me to say that even at the state level, so our state has a very robust tobacco control program. They're funding the cessation centers, which one of them I run in New York City. And yet when I said to them, so our deliverables are to work in federally qualified health centers and safety net settings in New York City, and behavioral health settings. And when I said, well, I work in dental settings too, which are safety net healthcare providers, they said, no, you are not allowed to work in those sites. You will be completely non-compliant with the deliverables for this grant. And I'm just saying that out loud, even though it may get back to the state, because it's just sort of unbelievable that that is the case. And when you talk about safety net healthcare settings and don't include the safety net healthcare settings, dental settings, that doesn't really quite make sense. The good news is that Healthy People 2020 for the first time included actually dental screening as an indicator, which was kind of really exciting and shows that at least at the federal level things are changing a little bit. So just to give you, this is kind of old, but just to, is there a little dot here? No, okay. So to point out that this was an interesting survey of about 2,800 providers across the country, and dental hygienists are always sort of up there at the top, asking screening and providing counseling. What I think is most striking, and this continues to be the case, that dentists don't prescribe. No matter what we do, they just don't want to prescribe. And these are pretty simple, straightforward medications. Most of them are over the counter. And the reason why that aggravates me a lot in New York City is because Medicaid covers these medications. And so dental providers can write these prescriptions for their patients and they can get it for free. So there really is no excuse not to be doing that. And dental providers, of course, can write those prescriptions. This is just another study that we did of about actually 1,800 dental providers nationally. ADA gave us this. And again, more recently. But again, you see the pharmacotherapy pretty low, although screening is up there. I mean, screening across the board is good. But we know that screening doesn't translate into treatment. And so we really can't stop there. So my efforts are really focused on really the cessation assistance component. So what are the barriers? We, again, in many of our studies and studies that Dave Albert up at Columbia has done, they're not that different. Providers are the same. Training, lack of time, workflow, and EHR integration are the huge challenge right now across the board. Lack of reimbursement, docs say that, but honestly, now Medicaid actually pays for smoking cessation. Do you know how many providers are actually billing for that? 1%. They're not using it. And what's really exciting is that our city health department really rallied and advocated at the state level when the state actually added that, which was recently. It was only 6 years ago. They added the counseling benefit. So medical providers can actually bill Medicaid when they counsel smokers. They didn't want to include dental providers, and the city health department came forward with just a huge effort and finally got them to say yes. That's great, but now I'm in dental sites, and there's no billing code in the EHR. Nobody's implemented. I'm actually an implementation scientist, so this kind of stuff really gets me. And we talk a lot to the state about, you can't just pass a policy and not think about how it's going to be implemented on the sites. Concerns about patient resistance is interesting, and scope of practice are particular to dental practitioners. This idea that patients might be resistant to this was sort of interesting to me. And when I talk to the residents, students, faculty, I say to them, as clinicians, we tell patients to do a lot of things they don't want to do. That's our job. And there are 2 published studies that show that smokers actually are much more satisfied with their provider visit if they've been asked about tobacco use. I don't have that data in dental settings, but I suspect it's the same. We actually went to the state. Dr. Bertoloni was very helpful, and actually had the Department of Education change the wording on the scope of practice for dentists, related specifically to tobacco use, just to make everybody happy. So it was really clear that it was well within their scope to not only counsel, but also to prescribe. So in my travels through dentistry and medicine, I've really get this feeling, as I said, it's almost a little disorienting. These are just completely parallel universes, at least in New York City. I have a grant. I should just explain first. I have a grant from NCI that is a 3-arm cluster randomized trial. We're recruiting 18 dental clinics, so these are public health clinics, and they're randomized to what we call current best practice, which is training a clinical reminder system or sort of some kind of documentation system, and a system to make sure they can refer patients to the state quit line. Arm 2 adds performance feedback, and Arm 3 adds pay for performance. And what's had been interesting to me is that all the studies we've done related to sort of chronic care model components, none of that work had been done in dental settings. Nobody looked at pay for performance. Nobody's done performance feedback. What about clinical decision support? These systems that we think, and there's some evidence for, that improve quality in the medical setting have not been done in dentistry. But anyway, in the context of this current study, it really came into focus what the issues are. And people have reflected on this today, so I'm not going to spend a lot of time because folks have talked about this. But what was so astonishing is that even in a clinic, like a health and hospital, I know some of you may know Health and Hospital Corporation, it's the largest public health system in the country. They have dental and medical. Their dental sites, well, they're not using Epic yet, but they will be. They have completely different EHRs. And not only do they not communicate with each other, but the dentists don't even have any of the pharmacotherapy, cessation pharmacotherapy in their medication list. They have to get out of their chart, go into the medical side, and actually get those medication lists. And it's been really, really challenging to try and make that happen. And what's so striking to me, because partly I'm doing another grant right now in parallel. I have a grant from AHRQ that's part of the Evidence Now initiative. It's this huge $100 million investment AHRQ is making in practice transformation research. And I've recruited 250 medical practices in partnership with the City Health Department and Community Care, Health Care Association of New York State to study practice facilitation to implement the Million Hearts Guidelines, which is aspirin use, blood pressure, cholesterol, and smoking cessation. So I'm doing, sort of a very similar thing, but what I'm going through with these practices is all the, external context that they're dealing with. It's making it very difficult to do this work, which is this complete move to value-based payment and all the sort of incentives that are driving these primary care practices, and that whole conversation dentistry is being left out of. It's, yes, the meaningful use attestation is possible, but as we saw, very few are taking advantage of that. And the medical sites are really driven by, these new payment models and QI initiatives that feel, and that's just not the case. And those two things need to come together. And of course, Medicare and dentists, oral health isn't covered by Medicare. And so they're left out of this huge Medicare initiative to change the way, we do reimbursement, and sort of dentistry is not at the table. And so all the billions of, the dollars that are coming out of CMMI, with all that research, it would be great to include dental sites in some of that work. So this is the chronic care model. And the reason why I'm sort of even bothering to show you this is that it's how I've been, federally qualified health centers have for years used this model as their model for improving care, quality of care. And, all these different systems. So some of you may be very familiar with this. The model that's sort of taken its place is the patient-centered medical home, which builds very much on this model, though. I'm really out of time. I didn't realize that, sorry. This is a study that we did where we looked at these different components and how they related to adherence to the tobacco use treatment guideline, and found, in fact, many of them did. And the more elements you had, the better you were doing. And so these are the things that we're trying to implement in medical settings and in the dental settings. And again, using a very similar approach. I'm going to skip through this to make it simpler. It's basically training, performance feedback. Again, within the concept of the study, we're doing pay for performance, and system changes, reminder systems, clinical decision support, and referral systems, which have been shown to be effective in medical settings. And this is just an example, and one of the things that's been said is that quality improvement is really not part of the culture in a lot of these dental settings. And so putting together this patient performance feedback tool and even getting the data out of the system was really, really difficult. And then this is just an example of something we've had to do in Dentrix at the health and hospital sites. Is they didn't have the bottom there, you see tobacco user, yes, no, we had to program that in. There wasn't even a place for the providers to document tobacco use. And I'm not going to get a chance to show you the nice thing that has been done by Mark Wolf and colleagues, but this is what's happening at the New York College of Dentistry, NYU College of Dentistry, where they have this really nice flow sheet that takes you through here, and then after you fill out all this algorithm, the students, it's NRT or Shantex, and the patient gets automatically a printout that tells them how to use the medication, has the quit line number. And the last thing that I just talked about Mark today about was how do we get this information sent to the patient's medical providers, the EHR, so that we can link, close the link. So I'll just end by saying that, this idea of population health in both medical and dental school curricula is really important. We're adding a population health track actually in the medical school. It's a huge achievement, I think. Integrating oral health and Medicare programs. These shared quality metrics would be really nice across dentistry and medicine. Optimizing HRs. And the other thing at the bottom is, these RIOs, which are not funded really anymore, but the idea of this sharing dental records data really needs to include dentistry. Thank you. Sorry for going over.
Thank you. The interesting thing is that in the electronic health record that Mark uses and many schools uses, that the dental data cannot go from the dental EHR to the medical EHR, but the pharmacy data, what we're prescribing, actually goes to an outside vendor, a prescription vendor, and therefore goes to CVS and Walgreens, and the medical doc can actually then access that through the pharmacy vendor, Dr. First. So the pharmacy piece, actually in a very interesting way, is interoperable. That's the only good thing. Pharmacy is ahead of us. Okay, last but not least, Dr. Margarita Fontana is professor at the Department of Cardiology, Restorative Sciences and Endodontics, University of Michigan School of Dentistry, and she will talk with us about predicting and managing dental caries in primary healthcare settings, the need for research.
Thank you. Good afternoon. The dangerous thing about being the last speaker of the day is that I'm standing between you and a wonderful reception. Thank you.
We will have also Q&A.
Oh, Q&A. Well, then that saves me. Thank you, Judy, for the kind invitation, and it's been a pleasure from Dr. Slavkin, first presentation, to all my esteemed panelists today. So because we all play in the same playground, some of my introductory slides about why the need for some of this research in this arena of cardiology will sound familiar, but hopefully some of the studies that I'm going to be describing are going to be a little bit different. I also want to tell you that in the spirit of interprofessionalism, my specialty is cardiology, but I am many times called a cardiologist, and you do not want me taking care of your heart. So some of the premises that you've heard today many times as well. Targeted healthcare, and nowadays we use the term precise healthcare. You can call it risk-based healthcare. You can call it personalized healthcare. Is here to stay, right? It's paramount. We have increasing healthcare costs. We have constraints and resources, both human and financial, and we have a need to improve the quality of the care that we provide to the patients and communities that we serve. In the dental caries arena, because of the large disparities in dental caries that exist in this country and continue and persist to exist in this country, specifically when we think about the younger and the elderly and the different types of cultural, ethnic, and racial groups in this country, and issues with access to care, this becomes even a greater imperative, I think. And as many have said today, expanded partnerships with the medical community, and I'm going to call here medical community a broader term, healthcare community, nursing, social work, pharmacy, teachers, WIC program coordinators, et cetera, et cetera. So even though I'm talking about medical or non-dental providers, many cases, I want you to understand I'm using the term very broadly. It's a promising, and I would argue, like many of you have today, a necessary strategy to really address some of the disparities that we see in dental caries in this country. And it has been said many times today, children have greater access in the young ages of their life to medical care than to dental care. And therefore, we know that pediatricians, family physicians, nurses have been called by their own associations, by national guidelines, et cetera, to collaborate with us in oral health care. And we start to have some data coming up from states that have been doing this longer than others, for example, North Carolina, to suggest that the number of dental visits early in life that a child has, medical visits, seems to translate into some measure of reduced caries experience, as limited as the data is that is coming out. Now, you've also heard today that we have so many wonderful opportunities. You know, how many times do we get to see that we have the policies and the reimbursement in places to make some of these things happen? And yet, when you look at translation of some of these practices in many states, it's still very, very limiting. So we have the United Preventive Services Task Force recommendations. We have many academies beyond dentistry supporting the integration of preventive services into their domain. We have Medicaid billing in the state of Michigan, where I am at. A well child visit can add an additional, if it's Medicaid paid, $23 if you do a fluoride varnish and an oral health screening. And what we're finding is that private insurers are many times reimbursing almost double that on top of the well child visit. We have great resources, and we've already heard about the Smiles for Life, and I love their app. I don't know if you've seen the app. It's free. I love it as a dental provider, and this is not only a non-dental provider, but when we work in schools, when we work in non-dental settings, and many times we need images to explain what we're doing, this is a wonderful repository. And if you haven't seen the app and download it, I would urge you to do so. And I'm going to talk about the Michigan Caries Prevention Program. There's also other new players in the game. You might have seen, depending if you are a member of the IADR, et cetera, you might have seen calls for an Alliance for Cavity-Free Future grants. And these are new interprofessional grants, and they are due up to November. So if you haven't seen them, I encourage you to look at them and participate and send a proposal. We've all heard about accreditation standards in all of our academic and professional domains that are calling for this. And in the case of young children, I will tell you that while in adults, when we talk about caries prediction and caries management, especially caries prediction, unfortunately, nothing that has been shown to be a greater predictor of decay than having decay. So you almost have to wait for the disease to express itself with the current tools that we have. Research is trying to change that with the current tools that we have to be able to predict decay. Yet risk tools ask about other questions, primarily to guide personalized intervention and care more than for the risk prediction itself. But in young children, because they haven't had teeth long enough to have that collective experience manifested on the tooth surface itself, it seems that the questions that are collected from a questionnaire that a caregiver can easily complete do have very strong predictive power for caries in the primary dentition. Now, when we think about this targeted, personalized health care, let's talk a little bit about risk assessment. Right now, when you look at the recommendations from many of the academies, et cetera, as it relates to, you've heard fluoride varnish today applied to children by non-dental providers, et cetera. The recommendations in the dental world are based on risk. Right? The higher the risk of the child, the more frequent you're going to apply or not apply some of these additional interventions to the toothpaste that we hope everyone is using at home, fluoridated toothpaste. Now, in the medical setting, these recommendations initially were risk-based, and then they were changed to be basically more of a public health approach where everyone is getting this. And it's in part because we don't have validated risk assessment tools that allow us, based on evidence, to separate different groups into periodicities, different periodicities or different frequencies frequencies, and that we know translate into different health outcomes. So risk tools have been developed primarily for dental settings, not medical settings. We really don't have validated risk assessment tools for medical providers, and even within the dental field, we can't agree on which tool is better or not. And many have argued, if you look at recommendations worldwide, that we still need better evidence on how those risk profiles then translate into evidence-based recommendations that will impact oral health in the public. So we have a lot, from a research perspective, a lot of work to do. Now I'm going to describe to you, I'm going to talk very briefly about two projects that we have funded. These are large interprofessional projects. The first one is funded by NIH. The second one is a CMMI-funded project. And there's physicians and pediatricians and nurse practitioners and behavioral scientists and dentists and pediatric dentists and hygienists and et cetera, et cetera. So these are very wide groups. This first project involves Michigan, Indiana, North Carolina, and Iowa, schools of medicine and dentistry and public health. And it's a very, very, very large group and large enterprise. And the idea behind this project is to develop an initially validated tool to assess risk in non-dental settings. And we decided that we were going to design this to be self-administered, because looking in the future, once you have a tool and if you're able to validate it, if it's self-administered, you can put it in the hands of the patient, you can put it in different platforms. The ability of addressing the concern that clinicians always have, that this takes a lot of time, I don't know how to do it, how to incorporate it into my workflow because I don't get reimbursed to do the risk assessment per se, et cetera, et cetera. So if you put it really in other domains and other platforms, you might be able to get around that. And I won't tell you everything that went behind this. Now, this is an ongoing study. We have over 1,300 kids that we've been following since they're 9 months. They're around turning 4 right now. So I'm going to just share very, very limited data to just make some initial points. So this is just a set of our questions. We looked at responses at baseline. So these are responses by the primary caregiver when the child is around 9 to 12 months of age. And these are significantly different responses between our Medicaid enrolled primary caregivers of children that are enrolled in Medicaid versus those that are not. And I could break this down by different ethnicities, different races, urban or rural, in different ways. And so what you can see, I highlighted in white in this table questions that are related to diet. Either because of the child or the primary caregiver. And you can see in red the responses of the Medicaid enrolled, primary caregivers of children that are Medicaid enrolled, and in black are the responses of the non-Medicaid group. And as you can see, for every one of those questions, and I'm just showing you questions where there were significantly differences between those two groups, you can easily see, let's pick one. Do you often give your child sugary drinks in between meals? So 40% in the Medicaid group versus 12% in the non-Medicaid group. I could break this down to you by states and different types of factors, but what you see here is a unique opportunity for an educational component to be able to be addressed to certain subgroups based on certain factors that we know are related to caries etiology in the future, for example. When you have seen this multiple times, we have referred about this. The table on the top is from Bruce Dye's last analysis of the most current enhanced data in the United States regarding prevalence of caries in young children. The table below is data from our own cohort, from children when they were turning 2.5. We measured disease prevalence for dental caries with using the ICDAS criteria, which is a very detailed criteria that looks at the whole spectrum. I'm only showing you here lesions that are whole, that would have been children that you would really want to have provided intensive interventions to avoid having that stage of the disease that now requires probably a little bit more than what can be provided just in a non-dental setting. And as you can see, there's wide disparities, not only by race and ethnicity, as we know, but urban, rural, Medicaid, non-Medicaid. But I will make one comment. 7% of the children at 2.5 years had the disease. Most of those children were in the Medicaid group. But the majority of the children in the Medicaid group did not have disease at that stage. So if you use in a risk assessment modality, just socioeconomic status to drive that, you're going to have tremendous overtreatment, a huge amount of people that are going to falsely be classified as being at risk as not. Your sensitivity is going to be really good. You're going to capture those few that have, when they have disease, as you know, they have a lot, as Dr. Mercy knows very well. But there's a large percentage that does not. So we really need tools that can not only be sensitive, but can be specific. I'm showing you here the distribution of disease. There have been a lot of discussions in the literature whether the patterns of disease are changing in the U.S. population. We see the typical pattern of early childhood caries. The nice thing here when we're doing training for our non-dental colleagues is that if you're thinking about a 1 to 3 year old, it's very nice that you want to look at the whole mouth, but really the only thing you need to do is lift the lip. If you look at those upper incisors, those facial surfaces, that's where the majority of the disease is. And if you just want to screen children that might be at risk so that you can either provide more intensive treatment or earlier referrals, that's all you really need to do. And that's a really easy skill to teach. I want to show you this. This is data when the children were turning 2.5. We were looking at individual questions. We haven't done still the modeling to look at the complete model of the whole questionnaire. But looking at how some of the variables were relating to caries experience as these children were developing caries. And in red, I added 2 questions about fluoride. And you will see have very significant, not only high, but significant odds ratios associated with that child then developing caries. And one is the child doctor or dentist, and I can tell you the majority of doctors, these kids are not seen, even though we do, because of being a clinical research, very intensive follow-ups so that they can go to care. They're not following through. Prescribed fluoride drops or tablets, or the child receives some topical fluoride, tremendously high odds ratio. So I'm not trying to suggest here that fluoride is associated with causing dental caries, but I believe what you're seeing here is that the clinician is identifying risk and is acting upon some form of identifying risk, so that recommendation for fluoride is following up some of the risk factors. And we are going to be presenting some of this data at the American Academy of Pediatrics in San Francisco next month. So the second grant that I want to mention that we have going on is the CMMI grant, very quickly. It's called the Michigan Caries Prevention Program. The focus of this, even with all the wonderful reimbursement and recommendations, the application of the integration of fluoride varnishes and oral health screenings into medical settings or non-dental settings in Michigan was minute. And so we wanted to find ways to try to increase that significantly. So we have a program where there's a mix of technical assistance, and it's not only training the providers. We work with IT, we work with billing. We're trying to find best practices. We're trying to understand different types of system deliveries so that we can really understand implementation and create a good road map for implementation protocols. We're creating a referral tool with the registry that will meet meaningful use both for medical and dental. In Michigan, Medicaid is primarily administered by Delta Dental, so the tool will automatically self-populate with the Delta Dental database for providers that actively see children on Medicaid 0 to 3. So when the medical provider is trying to find a referral based on zip code, based on culture, based on language, it will be able to pull that from the database automatically and hopefully facilitate referral. I just want to get to some of the lessons learned. There's many impediments. We've heard about the electronic health record nightmares, the many issues around IT, and even after training, perceived expertise and sustainability of the expertise, et cetera. But I think the thing that we have learned throughout our implementation is the need for that champion. You heard this morning the word champion many, many times by many speakers. And what we have found is that champion is almost essential for sustainability of this program and practices as people rotate and staff rotate, et cetera, et cetera. So I'm going to end up with this slide. We really want that interprofessional care so that we can really change and enhance health. At lower costs, all working together. Some of these principles between dentistry and non-dental colleagues are very similar. Risk assessment, targeted, patient-centered, evidence-based care, and we can't do it together with dentistry. We're never going to be able to tackle the dental caries problem by ourselves. So thank you very much for the invitation, and I guess I'm not the only one standing before your wonderful reception. Thanks.
Thank you for all the speakers. So we have a little bit of time left for Q&A. Lots of questions.
Hi, my question is actually directed towards Donna a bit. Do you know how much the reimbursement is for smoking cessation, of which may be influencing this? Right. So I mean, I think I know how much it is as well. Right. It's between $12 and $25.
Right. Depending on whether
And
it's
so
3 or 10.
I think, saying that there's reimbursement and then looking at the time that it takes, so it's right between 3 and 10 minutes, you get $12
Right.
For doing it, which definitely influences. So I do think advocacy around reimbursement has to also look at equal reimbursement for equal types of services provided. For example, advanced care planning, which has now become a priority for Medicare because of its link to repeat admissions, high cost. Do people know how much they're reimbursing for that? $95. So I do think aligning with where you're seeing increased cost, smoking, cardiac disease, is there a way to do that? Because those are discussions that you can have with a private insurer as well as having with CMS. And I do think those are some of the conversations we need to move to when we look at how we utilize our data to make it a priority. Because for advanced care planning, the way that was done was really linking it to heart failure. And there's been some good work showing of how it can happen. It's harder to do, but those are opportunities that are available to us going forward.
Actually, the one more thing I will say, one of the other barriers was that many of the Medicaid, the dental sites that are taking Medicaid are capitated for the visit. And so they said to me, Donna, what, this has no relevance to me. We then did some investigation and found that they could actually charge on top of it for this particular thing. But that just wasn't clear, and it's a whole other bit of administrative nightmare, actually.
And I also think, I very strongly believe, working on top of the license, so who is doing this type of counseling? Is it the dentist? Is it a nurse practitioner in the dental practice, the way that Dr. Donoff has put in the dental practice at Harvard, or some other kind of creative, hybrid, thinking about who would be the best person to provide that and bill for that, because it doesn't not always necessarily has to be the dentist.
Right.
Okay.
Thank you very much. Hello, can you hear me?
Yeah.
Okay. So this question is pretty much open to the panel. So in 2002, I was a 20-year-old interior design student. And I was hired to be basically I was a care provider for an Alzheimer's patient with me and my college mate, who was 30 at the time. So obviously we didn't have medical training, but in exchange we were able to live there for free. And so that was my entry into the world of community health workers and the backside door of what people are doing to offer providence to their family. Fast forward, I became a birth doula while I was working. I was moonlighting as a birth doula for 7 years while I was working in an art direction agency. And that company had a really great benefit package for employees, and they were emphasizing helping families with expecting for new birth and or adoption. And there were all these services for the infancy aspect of this being a parent and what insurance benefits were intact. But as I was listening to you talk about oral care and flashing back to me being a 20-year-old taking care of an 86-year-old woman for 9 months, it was how if her son had access to providence of how do you care for your elderly person in addition to your child? So my question is there a dialogue with a life cycle? And maybe that's an entry point, because parents nowadays with generations are taking care of their newborns, but then also too, with the increase of baby boomers and all these senior centers being developed, it's okay, I got to take care of my newborn, but I also got to take care of my parents. And so is there an entry point from insurance companies to be able to? No.
The short answer is there is Jack.
Yeah.
And I hate that, because as a nurse practitioner in memory care disorders, we have 40-minute visits, which my primary care colleagues look at me and salivate. That 40 minutes goes by in a heartbeat, because when you think about getting pregnant or adopting a child, you have months and months and months of preparation, Humpty Dump books, all these resources. And the pediatrician can bill for talking to mom and dad or whomever the parents are without the child present. You do that with older adults, it's called Medicare fraud. But oftentimes, I have the person with dementia sitting there, and I really need to be talking to the caregivers and talking them off the ledge because they have zero preparation. You go to the Alzheimer's Association website, and they do have some generic stuff, but they come to me and the other nurse practitioners for things like, how do I deal with the extreme wandering or the violence? And you can't just write a prescription for Seroquel because it doesn't work. You have to go deep into the behaviors. I would love to see some type of program compensation. I mean, that's why I put my videos on YouTube, because there are things out there, but they may be developed by someone who took care of his or her own parent, so they had an experience of an N of 1, and that's based on their own experience, which is legitimate. But I take care of thousands. So I would like to see more information out there, not just on the oral health perspective, but also on the caregiving.
Thank you. Other questions?
Yes.
Oh, yeah, go ahead. You have the mic.
I have the mic. I've got the mic.
Yeah. I think it is.
Can you hear me?
Yeah.
Yes.
Yeah, I think you speak up.
This is for Rita. We just received a grant last week to provide an interprofessional educational program to help seniors who are living in the community have better oral health. And we are using both the Oral Health America's Wisdom Tooth project, a program to teach in 12 senior centers. And the team will consist of students from the nurse practitioner program at NYU, the School of Dentistry, and the School of Social Work. We're also educating 1,000 home health aides on dementia through another grant, but we're going to use your cue cards to educate 1,000 home health aides on how do you provide oral care to patients with dementia. And I know you put it, you tested it in nursing homes, from what I understand. I'm wondering if you have tried it in home care and how that works.
I've tried it unofficially by working with the family caregivers, not just in mouth care, but also in other ADLs. And reports I'm getting back when they come and see me in the clinic is it's working. We're also partnering with Washington Dental Foundation. I'll be flying out there in November, and we're going to be adding to these strategies, because as the study progressed over 4 years, we started creating strategies just there, right on site, depending on what behavior was going on, like using the toothbrush as a bite block. That's not in it. That happened halfway through the study when I was caring for someone with Parkinson's, and of course you always have an audience when things go wrong, and he bit down on the toothbrush, and what the CNAs were doing, where they were just yanking it out and causing the behavior, I simply grabbed a second toothbrush and used the first toothbrush as a fulcrum. And my team's, how did you know to do that? I'm just making this up. I mean, I'm just, typical Nurse MacGyver thing. I just wanted to get the mouth care done. So we're also going to be training the trainers for a program that I know will be available online. And we're going to be doing videos with standardized patients to hopefully have additional educational clips available. So this may augment what you already are proposing to do.
Yeah, great. Okay, thank you.
Okay. Question in the back? Yeah.
Can you hear me?
No, I think you turned it off.
Hello? I work as a nurse in a cancer center, and my job is to get care for people with cancer. Typically, they are underinsured or no insured or Medicare or Medicaid. And I hear a lot from this group, and I'm really impressed with all the work you do as to encouraging physicians and nurse practitioners to be able to perform an oral exam and to make the appropriate referrals to dentistry, but how are we going to pay for that care? And I was hoping that somebody could speak to that.
How are we going to
How are we going to pay for the dental care?
in the oral cancer patients?
In any
In
patient.
any cancer patient,
But
okay.
patients who have cancer,
Sure.
I work specifically with head and neck cancer patients.
Okay.
So they need care before their treatment.
Yes.
And then lifelong, they have really significant problems, but they can't afford the treatment.
Yep.
So how do we make that as a Medicare covered scale?
Right. I'm going to ask Jim or Mary Lee to give that a first shot. Although I know you're both not Medicare, I understand
No,
that,
no.
but you're more into payment.
Yeah, I mean, just a couple things. I think, one, sometimes it's covered under their dental plan if they happen to have one of those. Okay? Two, I think if we make the case economically that there's dollars saved over on the medical side because of something that you might do on the dental side to reduce the level of inflammation, even if it's not a chronic disease, but if in this particular case, you may get the interest of the medical carrier to say, the cost that I pay for that dental treatment is less than what I would save by doing that, so therefore it'd be a net benefit for me, and perhaps the medical carrier might give it some consideration.
And I would think if they have a Medicare Advantage plan, that might help versus just straight up Medicare or gap coverage.
The MA doesn't.
Okay. There's a lot of more advocacy to be done. I have a very specific payment. Did you have something to add? Go ahead.
I was going to comment that some of our Medicare Advantage plans do cover dental services. I know some of them specifically exclude it, but some of them do.
Right.
But the bigger question is, how do we get CMS to hear? And I know it's something that we've talked about at Harvard, at the last Harvard Forum 2 years ago. We'll certainly talk about it at the end of October. And it came up earlier today. So there's lots of data. How do we get the word, and what's the tipping point?
So I have a very specific payment question, and then I'll get to your question. Obviously, fee-for-service is an interesting reimbursement structure that I think it's time in dentistry to think about moving away from that, certainly for the general dentist. What is your take on skipping pay-for-performance and moving to pay-for-value in dentistry? Is that even conceivable, or should we just go to pay-for-performance and try that first?
So at Aetna, our biggest foray into value-based care is in accountable care organizations. And up until now, the biggest barrier to dentistry being included to those is the facility. Most of the hospital systems in accountable care organizations don't have a dental clinic or any dental chairs. And then secondarily, it's the electronic health record. But we know of some dental providers, some are even represented here in the room today, who would love to try and be a part of that. So at Aetna, we intend to pilot that.
So could you uncouple it from the ACA and just say, take an entire dental school, take a, I'm sure Health Partners is an ACA in itself, but if you were not an ACA in itself, could you uncouple it or not?
Well, I think we too are looking at those kinds of arrangements. I think it has to do more with the sort of size and scope of the provider entity.
Right.
However you might define that. So with Health Partners, that's
Right.
a big group. You've got a lot of folks. You can make sure that you can run your actuarial numbers to be appropriate for what you can offer and what they need. You can probably do that with PDS.
Yeah.
You can't do that with 2 docs.
No, but you can do it with all the dental schools
And
together.
So,
Yeah.
Part, yeah. And
I
so
wonder
I
how-
think one of the
who
things...
gave them to you?
No, but I think one of the things that's going to be interesting for the payer community is this huge growth in the aggregation of practices, which is now probably 15, 16, 70% of all the care that's delivered in the country now, is that you've got models and size and scope to some of those arrangements where they're interested in risk, okay? So you can put models together that you can't do with that. It's been held back, I think, by the fact that most of dentistry has traditionally been delivered by very small entities who can't take on the risk of being put under some kind of a different arrangement.
Right.
It just doesn't work for them.
Okay. Thank you. I think we had a question. Oh, yes.
Just real quick, medical necessity, dentistry with a medical necessity. That comes out of the medical side of the insurance business, or is that become dentistry? On the reason I'm asking is the closer we get to cost-benefit studies, then be able to actually demonstrate both empirically, both with health outcomes, but the financial outcomes, that there is a decided benefit to treating something like periodontal disease. Example I'll give you is an immunocompromised, somebody who's going through head and neck cancer treatment, who presents with a mouth full of decay or abscesses. That's a medical necessity to have that treated before they undergo treatment, right? But as the closer we get to being able to prove a cost-benefit ratio here, can we not kind of make that same argument that there's a medical benefit to this? I mean, isn't that really where we should be going with that?
Well, I'll try again. I'll try. There are some states that have certain laws that describe medical necessity for dental, and if they do, it's oftentimes covered under dental. Usually it's not. Usually it's covered under the medical. The interplay between the dental plan and the medical plan, I think, is sort of key in deciding kind of where that goes. If they're married together, so to speak, if they're bundled, as in our term, where they sort of travel together, it really doesn't matter so much. When they're sold separately, it does. So if we're selling a dental plan, okay, all of those things that you would sort of say are unknown under medical necessity, the size, the scope, and the cost of all of those, are certainly not something that you're going to want to underwrite over on the dental side. Not with the premiums that you get on a monthly basis for dental. You gotta put it over on the medical side.
That's the answer right there. That it's a very complicated actuarial model. It has to do with premium payments. And so your example about the cancer patient who needs to get all of their oral problems taken care of before they can have cancer treatment, that scenario is covered in some of our medical plans. Right. But I get that question a lot, by the way. And what I find that a lot of people don't know is that increasingly employers are insuring their population. So the majority of our plan sponsors at Aetna are self-insured, right, and we administer for them. And they call all the shots. So we offer them a variety of plans, and they buy what they want or can afford. And they make the decision on whether or not that's covered. And it's all about cost.
All right. One quick
well,
thought?
We have that same kind of arrangement. Well over half of our business now is ASO contracts. So, you know, the purchaser out there is making all of those decisions. We'll put in front of them lots of different ideas with lots of different things, with lots of new codes or lots of new things they can cover.
And evidence and data.
And with evidence and data, and sometimes they say, I'll cover it and I want to, figure out this is what it's going to cost you to do it. And they're self-insuring and they're sort of saying, nope, here's the level of cost for which I'm willing to absorb. So I've got to build a plan around what I can pay, because we're not insuring them at that point. We're not carrying any of that risk. They're carrying it all.
All right, thank you. Thank you. And with that, it will be the end of this panel, and it's been a terrific day.
Yeah. Thanks, panel. Wow, quite a day, huh? Really terrific. Let's give a hand to our wonderful keynote, Hal Slavkin, the moderators, and plenary speakers, all of whom have been so thought-provoking and have provided such a wealth of information, experience, and hope for the future. And now I invite you all to join us at a cocktail reception across the street and down the block at 433 First Avenue, the home of the College of Nursing and the College of Dentistry, and to know that tomorrow we'll be meeting over at 433 First Avenue as well for an interactive morning led off by Marcy Nielsen, the CEO of the Patient-Centered Primary Care Collaborative, which is in the midst of redefining the principles of the primary care medical home. And who do they have, as you'll see tomorrow, right up there as a potential new friend and inclusion, just as a little preview. And should be an exciting morning with Marcy leading off, breakout sessions, and then Ralph as our closer. So join us over at the cocktail reception, and see you then. Thanks, everybody. You've just been great.